Yeah, to add to that, my primary interest is hip and knee arthroplasty and difficult ones and revisions, but that lends itself, I think, to paediatrics, and I really love paediatrics during training and went through the 3 centres of paediatrics during my training, which is something not everyone does. So I take it seriously, and I really enjoy treating children and their issues and their problems and the post-traumatic issues that they come across. So I hope it's not too basic. Go through a bit, I thought, first of talking about development of bones and how they straighten, how they grow, and how they heal from fracture. And then I just got a list of things to not miss at the end. So if it's questions along the way, please stop me and give me a yell. So first of all, how are the bones made? Once they're there, how do they get bigger? And how do they straighten themselves when they're bent? And I think that's kind of the crux of everything in paediatrics. A lot of it happens by itself. So you have to know a bit how the bones get bigger before you kind of go any further. And there's 2 real ways that bones grow. They grow between a membrane of periosteum, such as it's without a cartilage model, it's between a flat surface, or an endochondral, which is in a cartilage model, and that's like you get at the end of the femur, so it's within a cartilage model. So flat bones such as your skull, sternum, pelvis, intramembranous, long bones, and the sorts of things that you get with fracture healing, with callus formation, that's the secondary fracture healing. So back to embryology, from 0 to 6 weeks, a fetus is a bunch of cells and a bit of cartilage, and nothing makes a whole lot of sense, but it starts to get limb buds forming at about 7 weeks. And that's when bones start to form as a cartilage model. And from 7 weeks, the cartilage model starts to get bone growth within it, starts to calcify on the inside and get its own blood supply. And we call that the primary ossification centre, which is the diaphysis of the long bone. And then sometime after that, you get the ends of the bone forming their secondary ossification centres. And so there starts to resemble what we know as a long bone at that point. And so if we call the bit that's between the secondary ossification centre and the primary ossification centre the physes, we can then name the other bits of the bone, the epiphyses, which means above the physes, the metaphyses, which means below the physes, and the diaphyses, which is between the physes. And that's the names that we all know for how to describe different parts of the long bone. The physes itself is made up of different areas, and this is the key to understanding how the paediatric fractures heal, especially at the ends and how they straighten themselves. At the very top, and next to the epiphysis, you've got the germinal zone, which is where the stem cells start to turn into the cartilaginous zone, and they proliferate at this second area, proliferative zone, to then form what will become the hypertrophic zone, where they start to go large and get the calcification ingrowth. So this is the layer that you end up with your fractures through the physes. You've got above that the proliferative zone that's firmly adherent with the germinal zone to the epiphyses, the weak zone where they become hypertrophic and start to calcify, and the endochondral calcification zone is where it starts to then become the long bone. So that's at the point at where the fracture goes through. So if you think of the physes like the star, the bone grows away from the star, but it's also easy to think of it, if the diaphysis is like the base, then the physes is like a rocket and just flies up away from the long bone. So I think it's easier to think of what the physes does in that term. The bones not only get longer, they get wider as well. So our young bones in children around the diaphysis also have the big, thick periosteal layer, which then forms the bone on the outside in the membranous portion, so that they get wider at the same time. And that's also important for remodelling as time goes on. So out of all that, it's important to remember the way the kids' bones work, they are designed to break. Children are designed to break because they heal really quickly, and if you're going to break bones, do it when you're a child. We need to consider 2 types of fractures in children for the purposes of remodelling and growth. And so I'd like to put them first into extraphyseal type fractures. So these are the things that aren't involving a growth plate. From a healing perspective, you get a fracture, like on the left, that bleeds because bones have blood supply. The blood turns to clot, which then starts to get fibrous tissue ingrowth. We call that soft callus, and the fibroblasts come and take over, making the scar tissue, if you will, and then from there get calcification within, call it hard callus that you can see in X-ray. And then from there you get the mix of the osteoclast to take away the extra bone and the blast that put it down to remodel into the shape that it's supposed to resemble before and take up the functional load. So if we look at a healing fracture of a metaphysis in a distal radius, and you think of when that person moves their wrist, they've got a net force pulling down, like an axial compression at that point. But because it's off-centre, you're going to have a tension side and a compression side. So if it wants to dorsally angulate further, you've got the tension side on the volar side, compression. So the compression side stimulates bone deposition, the tension side stimulates resorption, so you end up with a bone that looks more normal as time goes on. And the body has an ability to remodel fractures that even off-ended distal radii are in good alignment will eventually fill in and look normal as time goes on. So that's dealing with the length deformity and translation, but what about the angular deformity? I like to think of the physies not just like a rocket ship flying off the ground, but it's also a little bit like a spaceship or playing around with the fire department. If you knock it over, it wants to kind of settle itself and keep growing in a straight line. So the angular deformity from the physies will not only right itself, but then you'll get the remodelling of the shaft proximal to the physies, and so you can do almost nothing to most paediatric bones, and they'll end up growing straight within reason. And we can remodel all sorts of horrible looking things without intervention. You often find that clinical deformity is not such an issue as well as time goes on. So we get excited about treating x-rays and looking at things saying it's dorsally angulated X degrees, but if someone's got a large proportion of remodelling, if you look at their arm and see what their arm looks like without taking into account what the x-ray looks like, it's never going to look worse than the deformity that you're seeing in front of you at that point. So remodelling will take care of the bones in the inside at a large proportion of the time. And I think as surgeons, we're probably guilty of over-treating metaphyseal fractures in kids a lot of the time. So we also need to consider what happens when it goes through the growth plate, so a physial type fracture. And being good orthopods, we like to kind of classify them further into things, and so we classify them first of all into the extraphyseal fractures, if you will, and then the transphyseal fractures. So a Solder-Harris 1 and 2 fracture, it's the most common things you'll see is where the physes are pulled off with a little bit of metaphyses attached to it. And it's important to know because that goes through the hypertrophic zone. The fracture exits down into the metaphysis. It's not damaging the germinal zone and peripheral zone. And so how does that work? Well, imagine that the physis is our rocket ship. The physis rights itself from its angular deformity. Ooh, I've killed my PowerPoint. Sorry.
Ooh.
Apologies.
Oh.
Didn't like my gifts. Yeah. Not that far. I'll go to here. Sorry about that. Yeah. So it deals with itself by physis will right itself, up, closed again. Grows in a straight line and the rocket ship goes off straight and the angular deformity corrects itself. It's a good win. So I won't go to that slide.
That slide's overwhelming, no, yeah.
Didn't like my gifts. That one, yeah. Fine, right. So, going back to that principle of a growth plate continuing to grow as long as it's not damaged, and the angular deformity sorting itself out, you can see this is a series of x-rays for a Solder-Harris 2 that's untouched over time. The metaphysis sorts itself back underneath the epiphysis, which continues to grow in a straight line. The angular deformity sorts itself out. And 6 months later or a year later, you've got something that looks normal again. So this is children are designed to break. So if we look at the ability to remodel, the highest potential to remodel is the closer to the epiphysis. But you've got to pick the epiphysis that's going to grow the most in a child that's got the most to grow. So as a take-home message, the younger the child is, the more of the ability to have to remodel a fracture that's not at perfect alignment. And in that child, the best potential will be in the physes that are going to grow the more. And how do you remember which ones? Well, this dude's sitting in the bath having a beer. If you can see the stars, they're the physes that grow the most. So about the knee rather than the ankle and the hip, at the wrist and at the shoulder, but not the elbow. It's not quite right because the ulna's got more potential to grow from the elbow than the radius does. The radius is up from the wrist. But it's an easy way to remember which of the ones you've got more room to play with. So a proximal humerus you can leave alone at 30 degrees, it'll be straight in here. At the distal femur, it's got more ability to grow, but we'll talk about the fractures there. So how long do you know you've got to go? Just as a side point, I think it's useful to have an understanding about it. But we suggest that girls usually stop growing at about 14, boys at about 16, but it's different for everybody, and people grow at different rates throughout their growth, so they'll speed up and grow really quickly when they're 2 or 3, and they'll slow down for a few years, and then they'll hit puberty and they'll shoot up like a rocket and then slow down again. So using the lateral olecranon, I think, is the easiest way to know where they are in their growth velocity. It's described originally by Silvergrain, but this is the modification that Demeglio has put. And if you think of the olecranon hypotheses, if you can see it's partially fused, for instance, if you've got an X-ray of an elbow, you know that they've got half a year of accelerated growth before it drops right off again. So their ability to remodel is much, much less. Whereas if they've got an olecranon that's a little round ossification centre, you know they've got bucket loads of time to go. So just as a side point, you might have to deal with that, but that's, I think, one of the easiest ways to know where they are in their growth development. So if we consider now the other types of growth plate fractures, the 3, 4 and 5, we have to think of this as a transphysial fracture, because you remember from where it was in the growth plate, it has to cross the physes to go out through the joint. And if you don't get the anatomical reduction of that, you'll end up with a bony bar, because you'll get scar tissue forming where the physes can't grow against each other. And that's where you get the problems of the physeal injury causing angular deformity, as part of the physes continues to grow and the other one doesn't. And that's the thing you need to recognise, that if you've got an intraphyseal fracture, that needs to be addressed. It can't be left in the cast and it won't remodel, or it's got very little chance of remodeling. So, in summary, take-home message from the development of the bone. Longitudinal bone growth comes from the physes. Children are designed to break. The physes will right itself and keep growing in a straight line unless it's injured. They have an enormous capacity to remodel angular deformity in the right person, and within reason you can't see the clinical deformities at the best of times, and the body will cope with it. And then you've got to be aware though of the things that will cause problems to the growth plates. That's just 10 minutes on how bone develops. Any questions before I move on to things not to miss based on that? So, not to be missed. Started from the wrist and worked back up again. Shoulder Harris 2 distal radius fractures are something that you'll all, if you work in ED, come across very regularly. And as you can see, for the young person with loads of deformity capability to correct, then there's sorts of things you can put in a half-baked cast, not reduce particularly well, and they'll probably be fine most of the time, like this particular person here. But the older they get, the less that they've got the growth potential, and you can run into problems of not putting it in the right spot. So here's one that I've dealt with at another hospital. It's a mash-up of various ones, but there's a half-baked cast that's got a poorly reduced distal radius and a fracture that's not, a cast that's not moulded particularly well. And you can see that at the 6-week mark, it's too late, you can't do anything about it. This person went on to have physeal closure because he was 16. At that point, you can see he's got a large residual deformity that is symptomatic for that patient. So it's important for your distal radiuses, especially shoulder Harris 2s, if you're going to manipulate them, have one go, put it on. If it's not on, let someone know who's going to take over it in the future. Because if it goes on to unite, you can't move it up for a couple of days. Then the person might not be able to deal with the deformity later on. So the older they are, the more of an issue it is. So anatomic reduction, one go, pass it on. Everyone knows about supracondylates in moving up the arm. A few things about the elbow that I think get missed or not poorly understood. But a supracondylar fractures at that point, it's extraphyseal, but the pillars around the olecranon fossa at that point are the weakest point of the arm. So they land in your arm, either rotation or hyperextension, it's going to hinge and fracture through the columns there, so it'll pull off. And treatment of that from a first aid perspective, I'm sure everyone would know, is to make sure that anything that's attached to the humerus at the front and folds into the elbow doesn't get damaged. So in that position, you can think the brachial artery, which will be coming down through the muscles at the front of the median nerve, are right there. They can get stretched where they're tethered from the ulna. So the first aid treatment for this is to splint them in a place that they're comfortable. So you don't have to crank them all the way out straight. You can splint them in 20 degrees, it's fine. But splinting is the treatment because you don't want to keep that fracture mobile. These are high risk for neuromuscular compromise. It does happen occasionally. If they're bent like this and you can see that they've got no pulse or can't feel one, but their hands are pink, you might get something when it's extended out. The scary ones are when they're white impulses, because that means that you really do have arterial damage. It's something that you're probably all aware. You need to pass that on straight away. There's nothing to delay referral for that. But that happens in a particular age group. So when you've got children between, say, about 3 and 10, we've treated them up to, before it starts becoming a problem with dislocation, supracondylar fractures. So if anyone's ever seen this, this is quite scary. This is a younger than kid that's 3. So you look at this, and this looks like an elbow dislocation in a child who you can hardly see the capitellum. The capitellum is the first ossification centre that forms in the elbow. And this looks like a dislocation, but that's impossible to happen in a child of this age. So if you've ingrained this image in your mind, if you ever see it, this is a physical separation. So it's essentially the whole distal humeral physis pulling off the humerus. They usually go posteromedially. And this is one of those fractures that's very high proportion of the time non-accidental injury. So it's a twisting injury or a hyperextension injury. So if you've ever seen this where both the olecranon and the radius are off the distal humerus, it's not a pulled elbow, just be wary about that and pass that on. It's a really scary circumstance. When kids get older, they don't have supracondylar or physical separations, they dislocate their elbow. But the problem here, and you get these teenage kids that dislocate, is that the things that the muscles pull off, like the epicondyles, are still got growth plates and weak points. So if you do go on to reduce an elbow in a young kid, it's so important to get your x-rays post. If you look at the x-ray on the left, that looks like it's a concentric reduction. The radial head's pointing at the capitellum, the trochlea looks like it's lining up with the ulna. But if you look at the coronal, you can see that there's something in there, and the joint's not reduced congruently. So that's an incarcerated medial epicondyle, so all the flexors have come off with it when it's dislocated, they've popped it back in, it's incarcerated within the joint. So just as your take-home message, if you see an elbow dislocation, you put it back in and make sure that you get good x-rays post, because you can see that sort of thing. If you left that alone, then that would be problematic to fix. Sometimes the median nerve can get, the ulnar nerve can get caught up in there. You can have real trouble. So,
would they have a symptomatic loss of range of motion for an incarceration like that? Or?
Yeah, absolutely.
Yeah.
But if you dislocate an elbow and put it in anatomically and the epicondyles there, they still won't want to move because it's sore. So if they're swollen, you put them back in. Sometimes you can't really tell that you're back in unless you've got an eye shot to show it. And straight afterwards, yes, they'll be sore, but I think that it's difficult to tell acutely whether they're back in or not because they're going to be so sore they want to move regardless. So I think imaging is important for those sorts of things. And if you don't know, you've got a question, get a CT scan, have a look, because you might see various bits of loose bodies in the inside of the joint. I think montages are something that I worry about since I was at the kids. You see quite a few children turn up with missed Monteggia type fractures. So that's an ulnar shaft fracture where the radius isn't fractured or it can be at the variance. But because the forearm acts as a unit distally, when you fracture the ulnar, the radial head will pop out because it's the point of least resistance. So this is blatantly obvious. You've got an ulnar shaft fracture, the radius intact, the radial head's not pointing out. So these are not difficult to miss, but they can be a little bit harder. So take this example, for instance. This is a pretty unremarkable buccal fracture at the proximal ulna. And we normally say to people, you've got to make sure the radius lines up with the capitellum. And you can see this does, but the sagittal film will demonstrate that that's out. So if you're worried about it, or if you've got an ulnar fracture with the absence of a radial fracture, you've got to have good orthogonal x-rays to demonstrate the radius is actually located within. So that's the importance of that. But then if you take it one step further, this looks like an olecranon fracture in a kid. But I put it to you, an olecranon fracture like an adult where the triceps pulls off can't happen in a kid. So this, if you see that, I would treat that as a Monteggia fracture until proven otherwise. And you can see in this particular kid that the radial head's dislocated at that point. So personally, if I have anyone with an isolated ulnar fracture who's a kid, and you notice or you're worried about any pain around the radial side of the elbow, I think we should treat that as a Monteggia and stabilise the ulnar so that until the radial head's located and it's stable. Because if you miss it, you put them in a plaster, send it to the clinic in a week or two, and the radial head's out, it can be a right pain to put it back in. And sometimes you actually need to osteotomise the ulnar to get the radial head back in, and that's a massive undertaking in a little kid. So the take-home message there is if you've got an isolated ulnar fracture, can't see anything with the radius, be just really, really worried about the fact that the radial head might be out. So there's a couple of examples there. Moving on to the upper